Assalamu alaikum wa rahmatullahi wa barakatuh. Yes, sir. Yemeni American Medical Association of North America, YAMANA, أن تقدم لكم YAMANA Education series. اليوم إن شاء الله راح نبدأ cardiovascular series, and the first lecture will be presented by Dr. Mustafa Hashim, and the topic is about acute coronary syndrome, and this will be the first part of 4 parts inshallah. Today we'll start the first part of acute coronary syndrome مع Dr. Mustafa Hashim. Salam.
Fast. So the first case will be 66 years old gentleman who presented to the emergency room for chest pain for 30 minutes, pain mostly at rest, but now he feels comfortable. Chest pain is central, radiating to the jaw area with some diaphoresis, which is sweating. These episodes are exertional, last for the last 2 weeks. He has history of high cholesterol, control on atorvastatin or Lipitor, as you know. EKG is normal. The high sensitive troponin 0 hour was 12, and then it doubled in 2 hours, and the delta level is 10. So we'll talk more about this detail, what the delta means, and then how important to measure that. Then it shows as next slide. Where's my next slide? All right. So what we would do with this patient, how are we going to interpret this? Is it highly probable of acute myocardial infarction, and we need to take this patient to a cath lab? Is it an uncertain diagnosis, and we need to get another troponin check in 6 hours? Or it's uncertain diagnosis and order CPK, or uncertain diagnosis, we get a CT, or we just watch the patient in the emergency room. So I'd like you to think about that patient. Basically, it's have chest pain. It seems to be typical, elevated troponin. What is the next step we're going to do? And this is one presentation of patient with acute coronary syndrome, and we'll talk about it a little bit more. Second patient is like a midnight, 60 years old woman, come with the chest discomfort, has a troponin of 900, discomfort relieved by nitroglycerin, and EKG almost normal, as you could see, guys. Now, what we should do about this patient, again, we're going to readdress this, but I really like you to think about this question again. Do we need to do a CT scan? Do we need to recheck the troponin? Do we need to do EKG and consider taking the patient to the cath lab, or we check the Grace score on this patient and then reevaluate this patient for a cath in 72 hours. Third patient will be 72 years old gentleman who came with anterior MI, clear EKG, and did a cath for him, has multivessel disease. PCI was performed, which is primary coronary intervention, to the occluded LAD, and then what we need to do to improve his survival. Do we use a radial access rather than femoral access? We give high flow oxygen, or we give 2B3A, or do aspiration thrombectomy, or immediate multivessel disease. I'm going to try to educate you also about this. Fourth question and last question is 51 years old, came in with EMS with the local emergency department after acute chest pain 40 minutes earlier, hypertension. Patient is uncomfortable, blood pressure is normal, negative GVD, and lungs are clear. And this is the EKG, as you can see, guys, ST elevation, anterior leads with reciprocal changes in the inferior leads. What we need to do, this patient is, which is really correlated to the scenario possibly in Yemen. The nearest PCI hospital, approximately 90 miles away. What should we do about this patient? With the total estimate of transport of 90 minutes, should we transfer the patient to a primary PCI hospital? Should we give TBA for this patient, or TNK, or we just give a half dose, or we do a full dose of thrombolytics, admit to the ICU? So I'm going to try to address this. I think my slides are not moving. There you go. All right. So I have no conflicts and interest of this lecture. and I'm not getting paid. So the initial evaluation and the triage, the way we should think about these patients, we look at the symptoms which represent ACS, like chest pain, short of breath, discomfort. And then the concept is how we risk of the adverse outcomes. Hello? So that's the main thing. We look at the symptoms and then we see how can we risk stratify this patient and improve their outcome. And that's really the key for these patients, because time is muscles with patients when it comes to the heart and it comes to acute myocardial infarction. So you guys still hear me? Right? You hear me?
We hear you well.
Yes. Great. Okay.
We hear you well. I have not get any feedback from USTH, بس ما في أي رسائل أو complaints. I will say keep going.
Beautiful. So with the approach for non-STEMI with ACS emergency department, clearly the role starts from the pre-hospitals. Basically, in the United States, we have these paramedics whom they respond to this patient. They go to the houses and they do an EKG, and then the EKG get transmitted automatically to the doctors and the emergency rooms, and then we activate normally the team. And we have to factor this because this actually shaved the door to balloon time for us drastically here in the United States. In Yemen, of course, I'm not sure how available is this, but this can be approached at the governmental level. How can we help this in the future? Now, the second approach, when a patient hit the emergency room, of course, there is a role for the nurses, registered personnel, patient when they come with a chest pain. The main thing is to do an EKG for them, show it to the doctor, and then communicate with the team on call, including interventional cardiologists, and then how we approach these patients. The third thing, which is really important, many times patients with acute coronary syndrome, whether it's STEMI or non-STEMI, they do present, they can have atypical presentations, especially in women's diabetics, older patients, and sometimes also younger patients. The concept is to have high index of suspicion, how we handle these patients. Now, so when the patients hit to the emergency room, we get evaluated. The most important test, which is the cheapest test, we do a 12-lead EKG. If there is a clear ST elevation, clearly we activate STEMI team, and there's a protocol that is established in every hospital here, and we can go to that at a later time. How can we help our colleagues in Yemen how to establish that and how to communicate that? Now, number two, if the EKG is normal, whether there is ST change or there is some ST changes, but there's no clear ST elevation, then we stratify the patient by checking the high sensitive troponin. Clearly, if they have positive troponin, they go to the non-STEMI, and if they negative troponin, basically we diagnose angina. And field approach closed for those patients with high non-ST elevations. And the key is some of those patients, they could have closed vessels, and then we need to handle that accordingly. Now, the real question is, we should be asking all of us, is the artery open or closed in this patient? Because really, the catch is, if the artery is closed, then you're really running against time. So how you find out whether this patient has a closed artery or open artery? Of course, you cannot predict it. You can just use clinical measures at this point in the emergency room. Now, non-STEMI acute coronary syndrome, how do you make diagnosis? We cannot underestimate history and physical examination, because that's the most important part of the evaluating of these patients. Now, we need to understand that EKG, it can be normal in a third of patients. So if you have a high index of suspicions, mean you suspect this patient could have acute coronary syndrome, you gotta revisit that patient and repeat the EKG in 15 to 30 minutes. Now, if the EKG is normal, like one of the patients I showed in the initial questions, then clearly you wanna do another, repeat the EKG with additional leads. You could do a posterior or right-sided lead to find out if the patient has posterior MI, or they have RV infarct. Now, continuous EKG monitoring, of course, is very helpful, but you cannot really diagnose ischemia or either ST elevation from just continuous EKG monitoring, but definitely will give you some hint in terms of ST changes, or patient gets tachycardic or bradycardic. That will help you. Biomarkers is the only one to use, is the troponin at this point. Clearly, there is no more rule in this day and age for the CPK or CKMB or any other test. Troponin is really the rule and the way to go nowadays. Some hospitals in the United States, they may end up doing a CTA. They call it a triple rollout. Basically, they want to check for dissection. They want to check for pulmonary embolism. Normally, we don't routinely do it, especially if you have a high index of suspicion and this patient have acute coronary syndrome. You don't want to delay the management of this patients, and you have to hurry as much as possible. Now, the high sensitive troponin, as I discussed, is the most important test you do in terms of biomarkers in these patients, because even the old assay of troponin, I'm not sure how this get tested back home, but the high sensitive troponin, actually, it can uncover for you the troponin blind period, which goes with the previous troponin. I mean, troponin normally rise in the first 3 hours, and that can rapidly roll out and roll in protocol. You can use it. We're not sure how much that can affect the mortality of these patients, but definitely it can affect the ED workflow, which is the emergency room workflow, in terms of rolling out and rolling in patients, especially if you have an emergency room which is busy. How can you strategize those patients? So one of the early rollout strategy, normally we check the troponin at 0 time, 1, 2, and 3 hours. And then based on that, because the high sensitive troponin, if it turns to be positive, those patients, they need to be triaged a little differently. That includes the EKG finding, and you look at the risk scores. Now, more important than risk scores actually is really your clinical evaluation of those patients and evaluating the risk factors. Now, we got to be cautioned a little bit here. Sometimes patients that will come a little bit late. Maybe their MI already happened 3 days ago, and then troponin is trending down. Then that's where the delta it has more high sensitivity of that troponin. Now, delta assay of troponin is not commonly used, but definitely it's written in the literatures, and the latest guideline from 2017, the European guidelines, are talking about it. Single sample can rule out only if the chest pain lasts more than 6 hours. So let's say somebody come and you confirm the diagnosis, chest pain more than 6 hours, troponins are negative, pretty much you can rule out myocardial infarction. In the United States, because there is a lot of medical legal issues with this patient, so people, they don't, normally they keep the patient and recheck another troponin in 3 hours to really confirm it. They don't just roll it out, but clearly by the guidelines, and you can defend yourself, if the patient confirmed that has chest pain more than 6 hours, troponins are negative, then you can rule out those patients. And if they have a low risk score, clearly you can discharge them and risk stratify them as an outpatient by doing a stress test or so on. So to reiterate what we just talked about, if you get somebody with acute chest pain, you check the troponin. If it's less than upper limit of normal, if the pain more than 6 hours, patient is pain-free. Grace score, I mean, don't get intimidated by Grace score. Basically, it's like a calculator. If you look at it in your Google, you look at Grace score, include age, diabetes, presentations, other renal function, and all that. Grace score less than 40, definitely you can discharge those patients, and you can stress them at your convenience as an outpatient if you need to. Now, if the chest pain less than 6 hours, then you recheck it again. If it's no change, then either no change means it's the same or negative, then you go with the same line. If your Grace score is low and the patient has a low risk factor, you can send them home. Now, if the troponin, it goes up, then that definitely diagnose an injury to the myocardium, and those patients, you have to go to invasive approach to those patients. Of course, if the patient comes in with elevated troponin, then you can recheck it again in 3 hours. If there is no change, which we can see a lot, sometimes patients have a chronic elevated troponins, like some patients like with the COPD, some patient with renal insufficiency, patient on dialysis, and those patients, you approach them differently, and then you take it from there. So if you have elevated troponin, to reiterate this, make it easy. If it's rising and or falling, then definitely you have acute ischemia, acute MI, and then you need to handle those patients. If there's no acute ischemia, then there's a myocardial injury. But if there's no change in the elevated troponin, it can be chronic, and those patients normally repeated offenders. They do come to the ER, and then also you can check the delta level, which can help you also. Now, so early or selective invasive approach for
دكتور مصطفى ممكن سؤال بس علشان في سؤال من ال listeners. What about TIMI score for evaluation of patient with acute coronary syndrome?
Yes, TIMI score is one of the scores you could use. There are a lot of scores. We're going to talk about those a little bit. I mean, you can use TIMI score, you can use Grace score. There's a bunch of scores I'm going to mention about them in a second. Okay. Yes. Okay. So risk stratification dictate the timing of coronary angiogram. So these are the scores which you could use. I mean, there's a lot of scores. You could use Pursuit, you could use TIMI risk score, you could use Grace risk score, you could use FRISK. At the end of the day, it is what is your clinical assessment of those patients. Now, if you have somebody, let's say with a low Grace score, like less than 90, but the patient is like, have elevated troponin, has really a real angina, chest pain, you won't worry about really the score. So, but I mean, people, they use all these numbers, scores and stuff, but at the end of the day, your clinical diagnosis, and all these scores actually infrequently used. Most of the time we mention them in the literatures or in the lectures, but for the purpose of the discussion, really your clinical evaluation of those patients. Now, so just to mention the Grace score, now again, most of the literatures, they will say if your Grace score 140 or more, those patients have high mortality, you have to approach them differently. If your score actually above 90, just think about it. If your mortality rate is like 3%, that's a very high. But again, if your risk score less than 90, but you have other factors, let's say somebody has a positive troponin, chest pain, some EKG changes, so you won't really worry about the score. But definitely we keep talking about this score, which can help and then educate the students and residents and all that. Now, so if you have high risk features, you get like refractory angina, you get hemodynamic instability, low blood pressure, you get patients who have like higher GVD, there are symptoms of heart failure, you get patients who got non-sustained VTAC, life-threatening arrhythmia. Those patients with no say, it doesn't matter what's the day and time, you got to take them for coronary angiography and define their anatomy and plan your therapy. Now, again, early invasive approach, if the high risk, mostly, again, we talked about scoring. If somebody has elevated troponin, dynamic EKG changes, EF is low, diabetics, bypass. But really, at the end of the day, elevated troponin is really the key. If you have elevated troponin because of sensitivity, we're blessed to have this test nowadays. So that will help you really to risk stratify a lot of patients. Now, the early versus delayed angiography, the debate is over for this patient now. Multiple trials. I mean, some trials that will tell you early benefits, some trials that say yes, there is a benefit if you approach these patients, but at the end of the day, there's no benefit of pulling off. Now, means if you have somebody who was in the middle of the night who has non-STEMI and have active symptoms or dynamic EKG changes, you're not gonna wait till next day. Now, of course, in Yemen, I can understand I'm not sure how many even cath lab they do have, to be honest, but I guess the ideal thing, the way we practice here in the United States, those patients, either they get an early cath in the morning, or sometimes we just go in the middle of the night and take care of those patients. Now, less recurrent ischemia and also the length of stay gets shorter for these patients, and everything here in the United States about a length of stay nowadays. Okay. Now, low-risk patients and troponin negative, ACS unlikely, and then you go with the patient preference, and also you go with the local ED protocol for the chest pain protocol. It's a big deal here in the United States, this chest pain units, how we stratify these patients, because we have a lot of patients, and then how we risk stratify them. So we do stress test early in the morning. The length of stay, they got to be discharged like before noontime. If they need a cath, they need a cath the same day, and then define them, and then just then expedite their discharge as fast as possible because of the load of patients we have here in the United States. Now, the optimal perfusion therapy for STEMI patients. Now, this is the curve actually we talk about in patients when they come with the STEMI, and I presented one of the cases who have anterior MI, but you would see this curve a lot, and I think you learn a lot from it. But if you look at the slope of the curve, now if you look at the first really 3 hours is really your gold standard, where you can really save myocardium. In the United States, I mean, most of the people, they talk 6 hours in the literatures, but actually the earlier you get to this patient, the better. Most of the time, and we take calls actually every night here as interventional cardiologists, we try to open these arteries in less than 90 minutes. The new goal by the new criteria is actually less than 60 minutes. We try to open all these arteries so the patient, they get discharged with normal LV function, and there is no consequences, because as you know, low LV function has a lot of increased mortality, and then has a lot of repercussions. Now, if you get somebody out of the window, like, and that's what we say, if you have like somebody is like in a remote place, and it will take more than 120 minutes to transfer this patient to a place where you can do intervention. Those patients normally, the ideal thing to give them thrombolytics, load them with Plavix or clopidogrel, give them their aspirin and transfer them. And then based whether they reperfuse or not, if they reperfuse, then you can pull them. You can cath them the next day or the day after. If they don't reperfuse, at least they will be in a place where they can be taken care of. But if you get a patient having already ST elevation and have chest pain more than 12 hours, it doesn't matter whether you reach them immediately or not. Now, of course, if they're symptomatic, if they're in a cardiogenic shock, if they have arrhythmias, you got to do them. It doesn't matter whether they're 12 hours, 24 hours, because you really don't know whether this artery is open or closed. Is it opening and closing? What is their anatomy? But definitely hemodynamically patient, hemodynamically unstable patients or in shock, those patients, they have to be taken. It doesn't matter what the time is. But if the patient is already more than 12 hours stable, then you really, it won't make a difference, because as you see, you cannot really salvage much of that myocardium. So it's really important to remember this curve and then ponder about it, and then stratify your patients accordingly. Now, the primary PCI per ACC guidelines from 2013 and 2015, which actually the ACC guidelines has not been updated since that time. The most updated guidelines, actually the European guidelines from 2017. But anyway, you got to follow your protocols and your regional accordingly. So if you're in a city, or if you're in a rural area, you got to build up a protocol for that area. So if you have a place where you're a remote place, you got to develop a protocol for that place and arrange it with the tertiary center in the main city. If you're in the main city, then you have to have a program how to be on call for these areas and take care of these patients accordingly. So the main thing is basically a door to balloon is less than 90 minutes, as we discussed. Now, of course, all of you guys are familiar with this class 1, class 2A, class 2B indications. any patient who have ischemic symptoms less than 12 hours, you got to take them. Patient with shock, irrespective of the time of the onset, you got to take them. Patient who have ongoing ischemia, then it's a 2A. Basically, there's census, you got to take them. Patients who have whether you, of course, if you open the culprit vessels, what do you do with the non-culprit vessels? Now, there's a little discussion about that. If the patient is in shock, the recommendation is not to fix the non-culprit vessels. It's like an oxymoron here, but if the patient is in shock, you don't fix the non-culprit vessels. If the patient is not in shock, then you can fix it within the same, either within the it's the question not answers, within the same setting or before the patient get discharged or within the first 30 days. But definitely patients with shock, you fix only the culprit vessels. There's a higher mortality if you start to mess around with other vessels at the same time. Now, we're all familiar with aspiration thrombectomy. Basically, it's a device, catheter-based. You use it to aspirate the thrombus, which is very intuitive to think about it. But actually, all the studies at this point is not recommended. It's a class 3 indication, means it could cause harm or increase mortality. It's a doctor clinical evaluation, of course, in that setting. I've used it sometime in the setting of STEMI, but it seems to be increased mortality, possibly because you're pushing that clot distally and it causes mortality on those patients. The initial guidelines used to call it a 2A recommendation, but nowadays it's a class 3 recommendation, clearly in the European Society of Cardiology. So this is the recommendation. European Society of Cardiology is the most updated one from 2017. As you guys familiar, but preloading with 2B3A inhibitors, there's no benefit of, B2Y12, sorry, there's no benefit of 2B3A inhibitors anymore. We used to give it a lot in the ER, nowadays we don't. Transradial is preferred nowadays. It's definitely, there's enough literatures to support the transradial approach for this patient in the STEMI situations or even elective situations, because there's a less bleeding, less mortality, less all that. Heparin as an anticoagulant, we use heparin here in the United States. We use drug-eluting stents. There's no more rule for bare metal stents anymore. Drug-eluting stents, because there's no difference in terms of using dual antiplatelet therapy, whether it's DS and BMS. DS has superiority in these situations in terms of restenosis. And then routine aspiration thrombectomy, as we discussed, is a class 3, short hospital stay, often no need for ICU care. Many times nowadays, you open this patient, they're hemodynamically stable, normal LV function. We don't even put them in the ICU. They can go to a regular telemetry floor and they can be discharged next day. Choice of stent should no longer be a question, as I discussed. Second generation drug-eluting stents, nothing to lose with it, which are proven to be safer, more effective. So it should be the default stent. No further discussion in this, at least in literatures, at least here in the United States. So then I'll run this case. 54 years old gentleman came with a STEMI to the emergency department. He was given aspirin ticagrelor. I don't know whether in Yemen what they use, but we use here ticagrelor or Plavix. IVN fractionated heparin was given, transferred to the cath lab within 21 minutes. He has a VFib arrest on arrival. CPR we was shocked ×5. RASC was obtained. Basically, return of his spontaneous circulation was obtained in 9 minutes. Blood pressure in the low side. You can tell this patient's in shock. This is his EKG, clearly speaking to you. Clear ST elevation, anterolateral leads, reciprocal changes in inferior leads. Clearly, this patient possibly has a proximal LAD, knowing the ST elevation involving V1 and V2. What do you go radial or femoral? For the sake of time, clearly radial is the preferred mode nowadays. I'm not sure how is the practice in Yemen, but definitely I think doctors in Yemen, they should be skilled in this at this point. So radial approach. This picture is not moving, but this patient has a proximal LAD. After obtaining flow of the LAD, the patient, this artery was opened in 21 minutes after the cath lab was arrived, and you can see the approach was a radial approach. So the purpose of this radial approach, basically, there is plenty of plethora of data, more than 5,000. It helps decrease all-time mortality, MACE, major adverse cardiac events decrease, access site bleed decrease, major bleed decrease. I mean, it's almost, number needed to treat is like in the range of 50. If you have a drug which you can use, you will use it by default if you only need to treat 50 patients to save one life or decrease one complication. So, and this is enough. We have enough data from 8,000 patient Matrix trial. Radial access is helpful. The spirit of this, basically, radial approach is the preferred approach. It doesn't mean that you cannot use femoral. Sometimes patients who have previous bypass surgery would prefer femoral because it's much easier and faster. Radial caths, they may not be appropriate for all the grafts, especially if you're using right radial and you want to access your lima. So radial access is class 1A recommendations for patients with STEMI or even non-STEMI or even elective interventions for the same reason. So now aspiration thrombectomy, this, as we discussed, basically as you see, you can aspirate clots. It makes you feel good, but the patients, they die more and they end up more complications. So no more aspiration thrombectomy, the discretion based on the doctor who's doing it at that point. So we don't do aspiration thrombectomy in the setting of acute MI at this point. So aspiration thrombectomy is gone. All right, so routine aspiration now is a class 3. Don't do it. We're done with that. So there's high frequency of CVA, no difference in mortality, almost aspiration combined. So basically, more mortality, more CVA in these patients. I mean, it could be just because you're sucking the clot, you go to the aorta, some of that clots goes away. It depends on the experience of the operator, and it needs some really training, and somebody has been doing this for some time to handle it properly. Yeah, whether you do complete revascularization, superior to carbureted vessels, I did allude to that. The idea is in the setting of STEMI, say primary PCI to the culprit lesions, stage revascularization remaining disease. There's some clinical benefit in observational studies, but selection bias. So there is a decreased need for subsequent revascularizations. It's underpowered studies. It cannot determine how to do this, but in general, patient with a STEMI, if they are not in cardiogenic shock, or patients who are non-STEMI, they're not in non-cardiogenic shock, stable, then you have the choice. Let's say you still have more contrast, you can fix it at the same time or the same index of hospitalizations or within the first 30 days. Patients who have cardiogenic shock, we fix only the culprit vessels. And this is basically cardiovascular death. If you do culprit lesions, only PCI, or you do complete revascularization, you have more improvement if you do complete revascularization on those patients who are non-cardiogenic shock. So just for the purpose of time, in acute MI with shock, mortality was lower among those who had culprit vessels rather than immediate multivessel PCIs. I'm still on time, Abdurrahim.
Yes, I think we are good.
Good. So 30 days mortality. Let me just move it. Right. Culprit shock results. We have 7 F6 patients. Again, the spirit of these slides, you fix only the culprit vessel, don't fix other vessels. There is a higher mortality in those patients. Now, this data has changed actually. 5 years ago, they used to say If the patient in shock, revascularize all the vessels, but nowadays the data showed it's not beneficial. Okay. All right, so any potential advantage of multivessel PCI is outweighed by mortality hazards of the initial longer procedures. Remember, the main proven goal in shock, rapid and complete reperfusion of the culprit vessels. Now, we do have a lot of devices we use here with patients in shock. We can talk about this further, inshallah, in the future. Pharmacology, non-invasive strategy, basically constraints on universal use of primary PCI. We have to think about logistic resources, especially if you have limited resources, especially back home in Yemen, and then you look at the timelines. And that's why it's really advantageous to, it is a cooperation between hospitals, doctors, and also at the governmental level, how we handle these patients, and every place develop its own protocol and how you cooperate on all this timelines. In the United States, many times we airlift patients from non-PCI hospitals to a PCI hospital. Sometimes we do transfer patients from even a PCI hospital to a tertiary center, those patients who need ECMO, Impala support. But we do have this in the United States. Now, if you're in a remote area back home in Yemen or here, some remote areas, knowing how big is this country, clearly you might need to transfer patients through your, whatever it takes, especially if the road is not good, but still you got to do what you got to do for these patients. Now, STEMI at the non-PCI hospitals, as we discussed, if there is expected delay more than 120 minutes, then you got to give a full dose of lysis, heparin, Plavix, or clopidogrel, and then you do a routine PCI based on the patient's. If patients improve clinically, then you can delay their PCI. If the patient doesn't improve, then they can reach the cath lab. The best thing is not to take those patients from a non-PCI facility directly to the cath lab or PCI facility, because there's a higher risk of mortality and thrombosis and intracranial bleed on those patients. Now, and this is really important slides, mostly possibly back home. Basically, if you cannot transfer those patients, you can give a TNK, you can give clopidogrel 300 milligram or even 600 doses. Nowadays we give 600, and you give enoxaparin, or United States we give heparin. Then 36% urgent PCI at median of 17 hours. At 30 days, their death, shock, heart failure, reinfarction, intracranial hemorrhage is similar. Now, you got to be thinking about those patients who are older than 75. You got to give them half the dose of TNK or TPA, because there's a higher risk of intracranial bleed on those patients. Clearly, there is a screening tool for patients before you give TPA, and I guess we can go over it next time, but I bet you guys are familiar with it. But at 1 year mortality, if you treat these patients, all-cause mortality and cardiac mortality are similar, especially if they improve. So you give them TBA or a TNK here in the United States, and then if they improve, most of the time, most of them, they reperfuse within the next 2 hours. It doesn't mean you don't cath them next day or the day after. You do cath them, you fix them, but so it is really an early non-invasive, but later invasive. Then the mortality is the same for those patients. Doesn't mean you don't cath them. So giving just the TPA or TNK and they get reperfused is not enough for you just to say, hey, this patient is doing good and they can be discharged. Again, we'll go to the slope of the curve as we discussed earlier, and I think this is an important graph to understand. Basically, it depends on when you're going to reach to these patients. As we say, lysis, then transfer for routine PCI. If it's more, you cannot reach to those hospitals in 3 hours. If it's more than 6 hours, definitely you can transfer those patients. The time is not a limit at this point because the myocardial death is already there, but still you need to cath those patients because sometimes you really cannot predict which vessel is open, which not is closed, and then whether they develop collateral, they not develop collaterals, and so on. So the key points for pharmacology treatment: consider at a non-PCI hospital, significant delay to PCI is likely. Facility to main basically device arrival much longer than 20 minutes. Genital therapy, keep Plavix. Successful reperfusion, look at the ST resolution in 90 to 120 minutes. The idea is to improve, look at the lead, which has highest ST elevations, and the resolution means it's improved by around 50% from that. It doesn't have to be completely normal. So it's more than 50% resolution from the initial EKG, and you look at the lead, which has the highest ST elevations. Routine coronary angiogram within 324 hours of PCI intent. You avoid routine immediate coronary angiogram because high risk of stent thrombosis and CVA in those patients, as we discussed. So routine early coronary angiogram reasonable unless clearly non-cardiac. Primary PCI preferred, and STEMI, DS stents to be used, drug-eluting stents, and no thrombectomy, as we discussed. Culprit only PCI and STEMI, especially cardiogenic shock. Stage revascularization is reasonable. At a non-PCI facility with any delay, go to pharmacology, pharmaco non-invasive, and review the guidelines, European Society of Cardiology from 2017, if you have time. So we go back to our first case. I'm going to go over these questions fast. I'll answer them for you. So the first patient is basically 66, 30 minutes of chest pain, now resolved, described as central radiating of the jaw. So it's classical angina symptoms. Troponin definitely went up as our discussions. Delta is positive, which is kind of give you even the spirit of that high sensitive troponins. So those patients, basically, they go to the cath lab, early invasive approach to those patients. It doesn't matter what's the GRACE score. If you calculate the GRACE score of this patient, possibly it will be less than 90. So it doesn't matter for the doctor who asked the question. So so this patient, they go high probable of acute myocardial infarction, admit and do coronary angiogram based on patient symptoms. You can do it next day, but during that index admission. Next patients, this patient came in the midnight, diabetic woman, chest pain 4 hours, recurrent pain in the ED, now resolved, hemodynamically stable, troponin is 900. This patient almost have a normal EKG. This patient clearly, I mean, troponin 900, normally it depends on the level. In our facility, our level is like, it should be like less than 18. So it's 900 now. This patient, you could repeat a posterior EKG, you could right-sided EKG. This patient easily could have a left circumflex occluded, because many times left circumflex doesn't show up in the EKG, but this patient needs to go to the cath lab. But the answer for this question, basically, repeat EKG using additional leads, consider urgent coronary angiography on these patients. So, and this is the angiogram of this patient, and you could say the circumflex was totally occluded, and you can tell this patient is, that's the best approach for this patient. And circumflex, as we know, sometimes doesn't show up in the EKG. So the other one, anterior STEMI, we saw the EKG earlier. PCI was preferred to the perform occluded vessel, which is the following action you need to do. And we said basically the high flow oxygen, there's no benefit. Use of radial axis rather than femoral axis is the right answer. As we said, we need to reiterate this. Radial axis is really important to be the preferred axis and get used to it, and have the right catheters, and ask your hospital to bring the right catheters for you to go radial axis in these patients. We said we don't use 2B3A upstream aspiration thrombectomy. We don't use immediate multivessel disease. It's very difficult to make a decision even before the patient to the cath lab, but we know in the cardiogenic shock patients, we don't do multivessel PCI. So those are the drive home point. No thrombectomy. In the cardiogenic shock, we don't do multivessel PCIs, and then we use radial axis in these patients. 51 years old, came to the EMS local emergency department, acute onset chest pain 40 minutes earlier, hypertensive, uncomfortable, heart rate in the 80s, JVD negative, so patient is not in heart failure. lungs are clear. ST elevation clearly, as you could see, all of you, this patient basically is going to take more than 90 minutes. The PCI hospital is actually 90 miles away from the total estimate time, transport time 90 minutes. Yeah, I know it's 90 minutes, not 120 minutes, but you got to count for triage in this hospital, triage in the other hospital, bringing the transport service. So it's going to be definitely more than 120 minutes. Those patients, they receive full dose fibrinolysis, transfer to PCI Coastal Hospital and monitor for evidence of any reperfusion. Clearly, if the patient older than 75, you give them half dose fibrinolysis because there's a high risk of intracranial bleed in patients older than 75. This patient got reperfused in 2 hours. His ST elevation improved, as you could see. You give them at least 2 hours for them to reperfuse, and most of the time they do. But it's like that's what basically a draw of the luck. But you're already moving and moving this patient to the right facility to be taken care of. And these are the patient was cath next day. You could see the LAD was subtotal and the stent was nicely placed. Patient's reperfused. A patient went home with a normal LV function, and his troponin only went up to 0.22. Just imagine how much myocardium is salvaged in these patients. Instead of going home with ejection fraction of 20%, he goes home with a normal LV function so he can take care of himself and his family. And thank you very much. And hopefully it was not that long for you guys. We're more than happy to take any question. I think we were on time. It's 2:11 here.
Thank you very much, Dr. Mustafa. Very informative lecture. Very valuable information. We thank you for your time. I know it's almost 2:12 in your local time now. There is a question about the question says, do SGLT2 inhibitors reduce cardiovascular risk? And which of them has cardiovascular benefit?
What was the S2? What SGLT?
Yeah. SGLT2.
No. Yeah, SGLT2. Now, you got to understand, SGLT2, of course, these are anti-diabetic medications.
Correct.
They do have the main benefit, these patients with patients who have ejection fraction less than 40%. Now, the companies advertise them in any patients who have congestive heart failure, whether it's diastolic or systolic. Definitely, there is some benefit, and we use them widely, actually, in the United States nowadays for patients who have mostly low ejection fraction. What I factor most of the time when I take care of my patients, actually the cost, because it's very costly, and some people, they cannot afford these medications, unfortunately, but definitely there is mortality benefits and less admission, especially with patients with congestive heart failure, yes.
Good.
I mean, you got to think about, you got to factor the kidney function, patients who have recurrent UTI. You got to pay attention to the other, what are the contraindications for these medications. And you have to, also you have to cooperate with the primary doctors. These patients, they need their primary doctor. They need to know that you're putting them in these medications so they can watch their blood sugar and stuff. There's some education attached to it. Yep. Next.
There was a question in the chat, say, in a huge ectatic vessel with high load thrombus, do you use aspiration thrombectomy or not?
Now, the data, as we discussed, the reason is we don't aspiration thrombectomy, it increased mortality mostly because of a CVA. Now, if you're the expert in this, clearly you can use it. And we said it depends on the clinical situation and the expertise of the cardiologist. Now, the initial guidelines from 2015, they used to put it as a 2A, means you can, it's everybody's recommending it. As a matter of fact, they would have make it even a class 1 indication. But not every MI you want to use. You don't want to use it routinely. Let me put it this way. I've used thrombectomy when I see a thrombus and I feel my patient will benefit from this. Now the key is when you use, I don't know what they use in Yemen, what we use Pronto, different devices here. The key is when you suck the clot, you got to keep negative pressure all the time till you remove that catheter off the patients. Otherwise, they're at high risk of stroke in these patients. Now, normally what I do, because what I know, I balloon the vessel. If I get a TIMI3 flow immediately and I can stent it, that's fine. But if I balloon the vessel and I don't get flow, definitely I try to do thrombectomy before I commit patients for stent. Yes. It should not be as a routine use. How about that?
Good. Thank you very much. Is there any benefit from DUAC after primary PCI, the neo-oral anticoagulant, direct oral anticoagulant after PCI, after primary PCI, Dr. Mustafa? Dr. Mustafa, أنت mute.
All right, got it. So yeah. The only benefit of using AWACS or DOACs after PCI, if those patients have other indications for those medications. Let's say somebody has atrial fibrillation, for example, right? Then you would use. You hear me, right?
Yeah, we hear you. Okay.
You would use one of the AWACS or DOACs. But also you got to use aspirin and clopidogrel, or aspirin or Abica and Berlin. Now, if the patient is high risk of bleeding, then you would cut one of the antiplatelets. But if the patient is low risk of bleeding, some practices that would use actually triple anticoagulant for those patients. But if it is only after stent and for STEMI or non-STEMI, there's no rule for AWACS or DOACs. There's no other indication for it.
So only if there is any other indication for it, like atrial fibrillation or DVT or
fibrillation or PE or so, or something.
Right. There's a comment from one of the people here. They said they've been using radial access for several months, which is good to hear. That's great.
That's awesome.
Yeah. Do you stop ticagrelor because of shortness of breath?
Now, ticagrelor has the reason it caused short of breath because of course it caused accumulation of adenosine in the system, and that's why it caused short of breath. Many times the main reason to stop ticagrelor is short of breath or bradycardia, but normally if the patient is tolerating it, they get used to it after like a week or two. So if you gotta weigh your patient's symptoms, and then if the patient's symptoms are not reasonable, then you can always give them a week or 10 days to see whether the symptoms improve. If it doesn't, then you can always switch them to clopidogrel.
Okay. Thank you very much, دكتور مصطفى. شكرا جزيلا على المحاضرة القيمة، وأعذرنا يعني سهرناك اليوم بوقت متأخر يعني.
No problem.
ولكن إن شاء الله يعني ربنا يكتبه في ميزان حسناتك. نشكر كل المستمعين اللي شرفونا وحضروا اليوم، اللي عن طريق الهاتف أو حضروا في القاعة للاستماع للمحاضرة. وإن شاء الله هذه تكون أول محاضرة من long series، يكون في زي ال cardiovascular series. دكتور مصطفى and his colleagues إن شاء الله will help in getting that set it up. وإذا في عندكم أي أسئلة أخرى أو اقتراحات أخرى بإمكانكم يعني إرسالها على الإيميل أو الواتساب، أنا بضيفه للشات. فإذا في حد معين عنده اقتراح معين أو سؤال معين بإمكانه الإرسال إلى الإيميل والواتساب الموجودات على الشات إن شاء الله. وبهذا نختم ونراكم في حلقة أخرى إن شاء الله.
جزاكم الله خير. السلام عليكم.